Welcome to Med-Surg Mini number 16 on airway management. One of the main forms of airway management is oxygen therapy. Oxygen therapy is the provision of oxygen greater than what is in room air, which is 21%. So by providing oxygen at higher concentrations, we can improve oxygen saturation of the blood and prevent hypoxemia and therefore hypoxia. It's implemented for a pulse ox rating less than 90 or a PaO2 less than 60 millimeters mercury. It can be used acutely or for chronic use, and factors that contribute to poor oxygenation include infection, obstruction, fever, anxiety, or anemia. We can measure oxygen therapy through a pulse oximetry reading, and the pulse oximetry reading is a sensor that can go either on the ears, the fingers, the toes, or the nose to measure the percentage of oxygen in the blood. A more accurate measurement is arterial blood gases, which are obtained from the radial or femoral vein to measure things like blood pH, oxygen concentration, carbon dioxide concentration, and amount of bicarb. The first type of oxygen administration that we try to use is a nasal cannula. This has a concentration of 24% at 1 liter, up to 44% at 6 liters. We can also provide a high flow nasal cannula, which can be provided from 7 to 15 liters. And another benefit of a high flow is it increases positive end expiratory pressure, or PEEP. This helps to keep the alveoli open and reduces dead space in the alveoli to improve gas exchange. We can also use a heated high flow nasal cannula, which can provide up to 100% oxygenation and up to 60 liters. The nasal cannula is a prong tubing that has a prong that sits inside the patient's nose. Then the tubing wraps around the ears and rests underneath the chin. This is the preferred site to start oxygen therapy. And the benefit is that it can be comfortable, inexpensive, and it allows for portable oxygen use. The downside is that it's more effective when breathing from the nose. So if there's any nasal obstruction, or if somebody prefers to breathe by their mouth, they may not get the full dose of oxygen being administered. It can also cause skin breakdown, particularly behind the ears, on the cheek where the tubing rests, and underneath the chin. It can also dry out the nasal membranes, which can cause nosebleeds and discomfort. So we can provide humidification with a nasal cannula. And then also, we especially want to monitor CO2 retention when providing oxygen at too high of a volume. The next type of oxygen administration is face masks, and you can see these lined up across the top. The first type is a simple face mask, which delivers 5 to 10 liters of oxygen at a concentration of 40 to 60%. The partial rebreather in the middle provides 8 to 10 liters of oxygen at 50 to 75%, or the non-rebreather provides up to 10 liters oxygen at 90%. The benefit to a face mask is it helps those that are mouth breathers, and it's effective oxygen administration at a higher flow. The disadvantages is it can cause skin breakdown where the elastic strap sits, as well as where the face mask rests on the face, and a lot of patients feel that it can cause claustrophobic-like symptoms. Then we have our Venturi Mask. This is the most accurate way to provide high flow oxygen delivery, and it's done in concentrations of 24 to 60% at 2 to 15 liters. The way it's administered is it has a fitted mask with an adapter vial to control oxygen concentration. As you can see, this adapter sits at the bottom of a flexible tubing that connects to a face mask. The adapter also connects to oxygen source, and based on the color can determine the oxygen concentration and liters that we administer it with. So for example, a light blue adapter provides 24% alcohol or oxygen at 2 liters per minute. 28% at 4 liters would be the white adapter. The orange adapter provides 31% oxygen at 6 liters per minute. Yellow provides 35 at 8 liters per minute. Red is 40% at 10 liters per minute. And green is 60% at 15 liters per minute. Then we have our aerosol mask. This delivers high flow oxygen with humidity, and it's often indicated after a patient has been extubated, has had airway surgery, thick secretions, bronchospasms, or airway edema. Then we have our face tent. The face tent has a little bit of a different structure. that it provides oxygen in a way that helps protect the face for those that have had facial trauma, burns, or upper airway surgery. And we have our types of administration from positive pressure ventilation. Two non-invasive options include the continuous positive airway pressure, or CPAP, or the bilevel positive airway pressure, the BiPAP. Both of these provide positive pressure to help keep the alveoli open during inhalation and to improve oxygenation. The continuous positive airway pressure maintains the same pressure, and it can be delivered through a nasal prong where the mask sits inside the patient's nose. It could be a full face mask or a nasal pillow. The bilevel positive airway pressure, however, has two different settings. They have a positive pressure setting for inhalation and then a positive pressure setting for exhalation. Typically, we would use a CPAP or a BiPAP for patients that are in respiratory distress or have sleep apnea. Then we have our endotracheal tube. This is a temporary form of intubation where we use a laryngoscope to provide a tube through the mouth down to the trachea. We set it in place with an inflated cuff or a balloon. The laryngoscope helps prevent us from putting the tube into the esophagus. This tube is then connected to an oxygen source, either through a bag or a vent. If we do connect it to a vent, it should be used for less than 10 days to reduce risks of complication like clotting and bleeding. This is beneficial because it provides an immediate opening of the airway. The disadvantages is it can cause a lot of trauma, sore throat, and bleeding. Another type of immediate airway access is a tracheostomy. This is a more surgical or a more permanent solution, and it is done through a surgical implantation of the tube into the trachea. On the left, you can see a form of oxygen administration that we can use with a tracheostomy, and we would place that right over the device, and this is called a T-collar. On the right, you can see different tubing, and that was what would connect to a vent. The tubing hanging down is an inline suction that allows us to provide suctioning at ease without interrupting the closed system. Complications of oxygen therapy include oxygen toxicity. So this occurs sometimes when individuals are receiving 50% or higher oxygen concentration for 24 to 48 hours. What happens is when this occurs, it can cause destruction of alveoli and it can inactivate surfactant production, compromising breathing. We typically see this a lot with COPD. We can also have absorption atelectasis, mucous membrane dryness, which I talked about a little bit earlier, where we could provide humidification. It can increase risk of infection, and also infection can increase our need for oxygen therapy. In patients with COPD, as I mentioned, they can be at increased risk for oxygen toxicity, and that's because they have decreased lung compliance. So they're not able to bring in as much oxygen, and if we provide them with too much oxygen, the body thinks that they don't need to breathe, and it can cause cessation of breathing. So typically, if someone has COPD, we would not do oxygen therapy unless their oxygen concentration is less than 88%. We also can develop trach bleeding, dislodgement of the trach, and complications related to that. Other ways that we can improve oxygenation is through incentive spirometry, coughing and deep breathing, early mobilization, pastoral drainage, which you can see demonstrated in the pictures on the right. So depending on where the patient's laying can drain certain aspects of the lungs, and you can see that indicated in the picture. We can also do chest percussion and vibration, and that's using a cupping sensation of the hands or a device to percuss the back to allow any fluid or mucus buildup in the lungs to break up. And then we can also combine that with a postural drainage to help that broken up fluid to drain. Lastly, we can provide them with nebulizer treatment and humidification. And that wraps up our Med-Surg Mini on airway management.